thank the JDRF for supporting some, and in fact, a fair amount of my research initiatives, and for an awesome community that I've seen form in Canada for fundraising and for research support. I'm sure a lot of you have met my dad at JDRF walks. He keeps telling me he just humbly goes to these walks. Sometimes I go with him. Usually someone starts chatting with him and then find out that his son is an endocrinologist and are all excited. He usually has a story like that after these walks. So thanks to all of you who've talked with my dad at these sessions. He's quite excited. So what I'd like to do is today acquaint you with some of the areas of my research. And actually, as a researcher, I could easily be criticized for someone who is a bit too broad-based. I have research initiatives in a number of different areas, and I'm going to explain to you why that is, and I hope that you can appreciate that. So it all centers around this photo, which I apologize if you've all seen before. I seem to have been using this slide quite a bit, but it is kind of necessary because it really frames where I stand in my interest in diabetes research. So that's me on the left, and my older brother on the right, Brian. And as kids, we had all sorts of aspirations. We've always been great friends, and we talked about the future and what we'd accomplish. But as a teenager, I was hit with that slap in the face of a diagnosis of type 1 diabetes. And my biggest fear was that Brian would move forward with his life, which of course I would support, but that I would be held behind in so many ways. And it took some time, but I came to realize with the kinds of technologies and insulins and screening for complications that I could really manage a life that it would be as adventurous and creative and satisfying as my brother's life. And so it's a key, sort of a key sentiment that drives my clinical practice and my research. But what I realized to accomplish that, there are two things you need to do. One is you need to prevent complications. And I realized that we really are lacking in some fundamental knowledge around complications, in particular around diabetic neuropathy, which is the most common complication of diabetes, believe it or not. For those of you who have diabetes or have family members that are younger, you won't fully appreciate this because it's a process that takes time to develop. The second thing I realized to lead that life, a full life with diabetes, is to be able to manage the day by day, to manage all the information and to make that background information one's day so that they can pursue their goals without troublesome hypoglycemia and still managing great blood sugars without it affecting their quality of life. So what you're going to hear about today are research initiatives in a few of those areas. In these 45 minutes, I'd like to familiarize you more with my involvement in what we've just heard from Andrew, the Canadian Clinical Trial Network, to appreciate the urgent need to better understand diabetic neuropathy and our use of a technology called corneal confocal microscopy for identification of significant neuropathy, and then to understand an extreme phenotypes approach to better understanding diabetes complications, and I'll explain in a moment. So I'll just kind of keep track of those things as we go along. So the first thing, the Canadian Clinical Trial Network, I'm not going to talk much about it. You've just heard about it, and I think there's more content at this annual general meeting. But I'd like to say that I'm kind of grateful because it got me involved in an area of research that I hadn't quite been involved in before, and it allowed me immediately a community of scientists around Ontario to work with. So I'm going to explain a study that we did, which was kind of a simple pilot study that kind of falls under the artificial pancreas umbrella, although technically speaking, perhaps it could be interpreted differently. Anyway, I will explain to you in a moment. But what I came to realize immediately when going to the large scientific meetings is that the artificial pancreas research is very much in pilot phase. You'll hear about a device and an approach, and it's tested out in a dozen or so patients. These are pilot studies. We want to see if it can work overnight and it can be reliable, and we really have to move this area further. And it's this kind of clinical trial network that will make it happen, and I realize that fully now. But back to my project, this pilot study of a continuous glucose monitor-based assessment protocol for basal assessment. So you may know that people with type 1 diabetes, whatever kind of insulin they're on, what's fundamentally important is having the right ballpark of basal insulin and the right ballpark of bolus insulin. And anyone who works clinically realizes that unless a patient understands those two ways of giving insulin, they will never fully be able to manage their diabetes so effectively. Because basal insulin is the amount of insulin that we need as a background insulin to prevent us from going into that terrible complication, ketoacidosis, but also just to hold our sugars stable when we're not eating. So if I get up to speak to a group of people and I'm not eating, I'd like to know that my blood sugar is being held stable, and I depend on my basal insulin to do that. And I can get that through an injection of a long-acting insulin or through an insulin pump. So if it's on an insulin pump and someone's not eating and their blood sugar does this during the night, that's a problem. That's a drop in blood sugar that you might notice into the low range. So we felt, even though an artificial pancreas, the job is to take moment by moment the blood sugar and make adjustments in insulin to help keep it stable. Right now, in the current practice, we kind of depend on people making adjustments to their basal kind of night by night or month by month. And we actually do a terrible job of helping to support people figure out their correct basal. So one way would be to have them wear a continuous glucose monitor, and we can look at the trend. And here, as long as I know when they had their last bolus, and it being earlier in the evening, I know that that drop in blood sugar is happening because of too much basal. So we, as clinicians, we look at this kind of data and we adjust basals. But here's a perfect opportunity to sort of semi-automate it. So if we, for example, now had a computer instead, a computer algorithm, analyze one segment of sugar compared to a few hours later, we know it's the basal insulin 3 hours back that's really deciding on that change in glucose. So if we're seeing a drop in that segment to the last segment, we would want to decrease the basal insulin in that very first segment, the insulin adjustment segment. And then we could now evaluate another set of segments and make a change in the basal and keep moving along through the night. So here the idea is that there isn't a change in insulin made on the spot, but that now at the end of one night, someone could wake up and their pump or some computer download that they've done could say, listen, last night we noticed when you hadn't eaten, your sugar dropped. You need to adjust your basal, and we suggest that the rates are changed from this to that. Change it now and repeat this tonight so that tonight, this next night, you don't suffer the same hypoglycemia risk. So I hope you can appreciate that. Artificial pancreas is meant to make the changes moment by moment. Here it's a strategy that makes a change day by day. So not quite exactly in the artificial pancreas mode, but what we designed is a internet-based analyzer that people can sign on to, and they can get instructions on how to perform an overnight basal, for example, to go in and submit a new one, and then review the results. So for example, if someone did one, we just want to make sure there's some quality control there, that someone who had that drop overnight didn't take another injection of insulin, something we're unaware of. So we asked them some screening questions. And then it takes the old rates and then suggests a new set of rates, and then it summarizes them in a nice table for them that they can access through the system. And now they've got a better approach for the next night. And what we did is a study where they did this sort of weekly, overnight basal assessment where they eat dinner and no further food until the next morning. It analyzed the basals, adjust them. It did that weekly for 5 weeks, and we could see what happened in this group of 20 patients. So I realized it would be nicer to show graphs with leaves in them, but I wasn't so prepared. So I'm going to show you some with dots. So what this is actually of the 20 people, what their average blood sugar is overnight from midnight to 7 a.m. That was the time period we were most interested in this study. And so at baseline, they had 3 days of continuous glucose monitoring studied. And here's a summary of the 3 days, 20 patients, what happened to their blood sugars. And one thing that I've seen over and over in different studies where we use CGM, like I do some exercise research, research with sensor-augmented insulin pumps, this overnight dip happening somewhere in the 2 to 3 a.m. range is just so consistent, like on average. Not everyone gets it at 2 to 3 a.m., but on average, there's this little dip that I hope you can appreciate there. So that is one thing that's important to eradicate. And so at the end of this 5 weeks of repeated assessments with our tool, we found that people had much more stable blood sugars. So we got rid of that overnight dip, as you can appreciate there. Although I noticed that their blood sugars look a little higher on average, and so maybe this would be an indication that we've messed up their blood sugar control. Because of course, if we prevent hypoglycemia, we still want awesome blood sugar control. We don't want to mess that up. But as it turns out, again, no leaves in this graph, and I'll just guide you with if you start at the top of that table, the hemoglobin A1C at baseline was 7.6, and 5 weeks later was 7.4. You might say, well, that's not a great improvement, but you might remember that an A1C is an average measure of sugar over 2 to 3 months. So a 0.2 improvement in 5 weeks is actually a big deal. So we saw that improvement in A1C despite that the sugars look a little higher overnight. And then really profoundly, the number of episodes of hypoglycemia, thanks so much, I appreciate that. The episodes of hypoglycemia at baseline was 1.6 episodes on average per 3 nights per individual. So people were having 1 or 2 episodes of hypoglycemia. But after this protocol over 5 weeks, it was cut down to half or 1 episode every 6 nights, for example, of even mild hypoglycemia. So that's a pretty profound decrease. So we felt that this is an important difference from this fairly simple protocol. So that work we're actually presenting at the American Diabetes Association next week, and we're working for publication. And the goal is to move that protocol. We've now worked with one of the CCTN members. It's called the Center for Global eHealth Innovation. They're at the University Health Network. We've helped to improve the usability of that website so we can now use it in a larger clinical trial and involve other investigators rather than just me and my patient population. But you've heard about the artificial pancreas concept, and essentially the way that in our era right now, we used to think, well, taking a subcutaneous or interstitial glucose sensor, which is not a measure of blood glucose, but of the glucose under the skin, the interstitial fluid, there's some lag. It's not a perfect measure of blood sugar, but it's pretty damn good for looking at trends in glucose. And then giving an insulin pump, the insulin goes under the skin, not into the blood where the pancreas would put it in. So there's some lags in sensing glucose and administering insulin that we thought would sabotage the efforts to use these technologies in an artificial pancreas system. But it turns out they can work quite well. So we don't need to measure glucose from blood and put insulin in blood, because to wear such a device has much higher risk of infection, to have indwelling catheters in blood. So it would be much better to have this kind of system. And so our project kind of got us into this domain, the basal assessment project. And now we've just got a study funded from another foundation, but we're going to initiate it this year. And I'm really hoping to move that pilot work further into the clinical trial network. But I'll just sort of explain conceptually what we're doing in our study. So in this study, or here's an example of an artificial pancreas. What it does is it looks at the blood glucose or the CGM glucose and makes a decision on how much insulin is needed based on where the level of glucose is and the change in glucose, how much insulin is on board. The sorts of things that we ask patients to learn and intuitively do themselves. Here the burden is partially taken off of the patient. Unless the sugars go way out of range, then the system will say, you know what, I no longer know what to do. I'm putting it in your hands, and it'll alarm the patient and say, eat or deal with this high sugar. But one of the problems is that even when let's say a sugar is dropping, we can decrease insulin, but that doesn't necessarily stop a sugar from going into the hypoglycemia range, because there might have been too much insulin given in the last minutes or last hours, and you can't take away insulin that you've already injected. So one strategy is to give a second hormone in the system, and that is the counter-insulin hormone or anti-insulin hormone called glucagon. So here, rather than telling the patient, waking them up at night and saying you're going too low, it would administer a tiny dose of glucagon, which can have big effect on raising blood sugars. So we call this a dual hormone artificial pancreas, and there actually are very, very few investigators internationally who are working in this domain, and in collaboration with a group in Montreal who's initiated work with this, we're starting this project this year, so it's very exciting. But I'm going to totally shift gears and tell you about my research in complications and specifically in neuropathy. So this is a completely different kinds of study. These are studies essentially of diagnosis. So you heard from Andrew about phase 1 through phase 4 studies in drug or pharmaceuticals. These are kind of different studies. These are trying to see, can we identify a complication as it's developing so that we can now prevent its progression. So let me just tell you a little bit about diabetic neuropathy. So you know that the fundamental complication that we've understood the best is retinopathy, seeing how blood sugars and the metabolic problems with diabetes injure that very fragile layer at the back of our eye called the retina. And the reason that we can track that so well is that we can actually, with instruments, look in someone's eye and see the retina, see the blood vessels, see the nerve layers perfectly well. But for kidney disease, we can take kidney biopsies, but that's actually extremely difficult. So we use a proxy measure of injury, which is spilling of protein, even small amounts of protein in the urine. And so we track those year by year along with an eye exam to look for the development of those complications. But for neuropathy, we do a terrible job. We don't have great tests that tell us that someone has initiated a pathway of injury to their nervous system. And we know that a lot of people who do not have retinopathy and do not have kidney disease can develop nerve disease on their own. Some people are very susceptible to that specific complication. So we need to do better in measuring that. But let me just tell you a little bit of why the nervous system is so susceptible. We have a brain and a spinal cord, and then these peripheral nerves, which are the ones that get injured in diabetes. They, for example, a sensory nerve will run from the spine all the way to the skin and will be able to tell the brain about stimuli like touch and vibration and temperature so we can sense the environment. Well, these nerves are bundles of individual nerve cells and their sort of extensions called axons, which single cells run from the spine all the way to the skin. So someone like me, I have individual nerve cells that are stretched out from my spine to the tips of my toes that's over 1 meter long. So you can imagine those cells are extremely sensitive to injury in diabetes. And when they get that injury, we can lose our sensation, or those nerves can have abnormal firing where it causes terrible pain. So the key thing or the key finding in people who develop neuropathy is this thing called a stocking and glove distribution of sensory loss. So they start losing sensation in their toes, and it can move up their legs, and as it hits their thighs, it can begin in their hands as well, and even the middle of the abdomen. And this ends up being a terrible situation, because if we lose sensation, then we can get little injuries that we don't notice that can get infected and lead to skin and bone and blood infection, and leads to the extremely high rates of amputations in people with diabetes. So that just sounded really depressing. In fact, I feel depressed at the moment. And actually, maybe I shouldn't even show this slide, but just to have some idea, this is, rather than showing you kind of infected ulcers, which are really tough to see at any time of day, let alone the morning. This is someone who had neuropathy and who came in with a skin infection at the bottom of the foot. And because of that loss of sensation, they had actually stepped on a sewing needle and were unaware of it. And it kind of led to erosion of bone and infection in that bone. So you can see how protective sensation in all of us is so fundamentally important to protect us. So the way that we can measure for any condition, there's a gold standard test. And the gold standard test to see if someone has nerve injury is to do this thing called a nerve conduction study. Have any of you had a nerve conduction study done by chance, perhaps in one of my studies? Oh, we got to get you involved in our studies. Okay, there are a few of you. These are not pleasant, especially with someone with diabetes, where it can be a little bit more difficult to make these measurements. It can take 2, 3, or even more hours to do the studies. And what we do is we put a little stimulating electrode, so it's like a wire right over a nerve distribution. This one's a nerve called the sural nerve. And then farther down, we put a recording electrode that measures the electrical signal, a little shock that goes through that nerve and runs here. And we can then look at the waveform pattern and see how big the waveform pattern is, but also how quick it is, to see whether it fits with normal nerve function or an impairment in that nerve function. So that's our best way to identify neuropathy. The problem is that it requires extreme expertise. We need technicians and in these specialized neurology units to do them. And in fact, we don't have enough capacity to do this kind of study in everyone with diabetes, nor would we want to, because it's not an easy test to take place. So my interest is finding better ways to make the diagnosis, but also find indications of that injury as it's starting, so that we can predict that one person who looks healthy in front of us now and another person who looks healthy, which one of those people is likely to go on and develop neuropathy. Because those two people can look exactly the same. They can have similar blood sugar control, similar metabolic measures, but one person might be initiating a pathway of injury to their nerves and the other not. So we call these studies of predictive validity. I'm interested in taking some measurement that's going to tell me, that's going to differentiate who's going to go on to develop nerve injury and who's not. And then we can do something about it, improve blood sugar control or study better therapies for neuropathy. So it turns out our earliest indication of nerve injury is loss of these little branches of nerves that penetrate into the skin. And they come from nerves within those nerve cells, within those nerve bundles that we call small nerve fibers. So they don't have this kind of insulation layer that we call myelin. These other nerves you see down here that are involved in measuring pressure and vibration sensation, or being able to sense when hairs on the skin are moved, these all have myelin around them, and they take longer to get injured than these tiny ones that go into the skin. And these tiny ones, their responsibility in the nervous system is to tell us about pain sensation and to tell us about temperature sensation. So it turns out we can take a biopsy of this skin, and it's fairly simple. You take a little skin punch biopsy. It's 3 millimeters long. You pull out this skin and look at it under the microscope. And here in this person who doesn't have diabetes, we see this nice candelabra of branching small nerve fibers, whereas someone with diabetes who's developing neuropathy, we can see a loss of those fibers here. But I'm sure you'll agree that as a clinician, I still don't want to be taking biopsies from people every year. So we learned that the cornea of the eye is essentially an adapted skin layer. It has so many similarities to skin, and even at a distance, if you squint, you can kind of see that here's a cross-section of skin, and this is the cornea. They both have this outer epithelial or epidermis layer. They have this whole support network that's called stroma in the cornea and dermis in the skin, and then this sort of interlayer which carries those small nerve fibers. And so we can use a high-powered microscope called a corneal confocal microscope. It was in existence, but we can adapt it to look at the cornea. And here, we can just give a little anesthetic drop and put a gel layer on the eye, and the person positions their chin at the microscope, and the examiner gets a side view camera that they can just gently bring the objective of that lens up against the gel layer on the eye. And so, for example, there's an examination, and we can see these small nerve fibers in the eye. And what we wanted to do is make sure that actually, this very much fits with JDRF's intentions. Forget making discoveries that are never going to find themselves in clinical use and actually benefit patients. We want to make sure that this kind of somewhat complicated technique could be made much more simple so it could become part of clinical practice. Like from our first steps of investigating this, we want to make sure that this could be performed in clinical practice. So one way to do that is to take the expertise out of the examiner's hand, have them just focus on any area of the cornea, then hit a foot pedal button, and then it starts immediately a sequence of going through 1 micrometer depth at a time through the layers of the cornea, and it does that automatically. And so the layers of the cornea, it starts with this outer sort of epithelial layer, and then it gets into these nerve fiber layers, which you can see we're going through now. And now in that film loop, we're getting into the long stromal layers. So in other words, all the examiner has to do is focus on any part of the cornea, hit a button, and then the rest is automatically happening in a few seconds, where it quicker than this film loop is showing, takes these images. And now the examiner can look at the whole panel of images and select out the handful of images that have the nerve fiber layers in them. And actually, if we took these images sort of side by side, you can see a cornea has this nice network of small nerve fibers. And if we sample any of these areas, you can see that you're going to get roughly the same kind of density measurement. So we found that in people with diabetes who didn't have neuropathy, and also in healthy volunteers, they have this really nice, dense network of nerves, and we call this the measurement of nerve fiber length. And then someone who's even developing moderate neuropathy, they have a big dropout. I'm sure you can appreciate that even from the back of the room. And we could also see that if someone has neuropathy, these are all people with neuropathy, this one has milder, more moderate, and more severe degrees. You could see that it could measure the severity of neuropathy. So here's a test that takes a couple of minutes that we learned gives us just as good information about whether someone has neuropathy as doing those complicated multiple-hour nerve conduction studies. But the other reason we're interested in this, I'll just take a moment. This is potentially a few minutes of your life that you could consider being lost, but I feel it's fairly important for you to understand from a clinical perspective in clinical research how we do these studies. And actually, I think you'll see they're kind of intuitive. So there's this thing, when we talk about validity, we want to see whether a proxy test, like using this confocal microscope, could be as good or as valid as doing the gold standard test called the nerve conduction study test. So I could decide I could take all of the people in this room who have diabetes, and I could spend the next 3 or 4 hours doing nerve conduction studies on all of you, and we could determine who's got kind of clinically relevant neuropathy and who doesn't. And so let's say in the room there are these people in red who have neuropathy and those in green who do not. Then I could, at the same time, do the eye test and measure your corneal nerve fiber length, an indicator of all the nerve tissue in that field. And in the analysis phase, I could separate controls from cases, and I could see whether the measurement of the confocal microscope is different amongst those with neuropathy and those without. And it turns out that it's excellent. I won't show you the leaf graphs on that, but it's phenomenal, so that we can do a really great job of identifying who has neuropathy and who doesn't. So that sounds great, but to me, that's still useless. Not perfectly useless, but not good enough. Because I don't care about identifying who's got neuropathy in this room and who doesn't. I care about identifying who's at risk of developing it so I can prevent it in the first place. And to understand how the confocal microscope works in that regard, we have to do a kind of study called a predictive validity study, where this is going to require like another 100 rooms of people to find out all those people who have no neuropathy at all. And then I only select those groups. I measure their eye findings as well. And then we let time go by, 4 or 6 years, because at some point, some people will develop neuropathy. And now we can look at those new onset cases of neuropathy compared to the controls who stayed without neuropathy and go back and see what kind of scores were associated with new onset versus those associated with never developing neuropathy. In other words, the only way I can really know if someone's going to develop neuropathy is to actually watch them over time and see them actually develop neuropathy and go back and see how these measures differ. And then suddenly, that becomes a much more clinically useful test. We can make those measurements now in our clinic and predict who's more likely to go on to develop neuropathy and who's not. So right now, this is a big focus in our research group to finish up a study funded by JDRF, which preceded the whole Canadian Clinical Trial Network, but is a project within the complications platforms with the JDRF. But I'd like to tell you that we're taking this research which is really a big finding in the neuropathy world, and we want to apply it to other data sets and understand neuropathy better as diabetes develops over time. And so we, not specifically for this neuropathy purpose, but for a number of other purposes, we've just initiated this past month a study that we call the Canadian Study for Longevity in Diabetes. You might have heard about the Jocelyn Diabetes Center in Boston that has a medalist program. Since the early 70s, they gave medals to people who survived with diabetes for 50 years or more. It turned out that in the 40s, most people, about half of people, even before they hit their 40s, were dying of end-stage kidney disease. And so they had a medal that was a 25-year medal. But in the 70s, we were doing so much better with blood sugar control and preventing kidney disease that Jocelyn got rid of the 25-year medal and instituted instead a 50-year medal. And they've been giving these medals year after year, and so they have a nice registry, and a group of researchers decide to study these folks. And actually, they learned a lot. One thing they learned, for example, is that people, even after 50 years of diabetes, there's a subset who appear to still be making some insulin. And that little reserve of insulin might help their blood sugar control, but to me also gives hope that some of these immune therapies, like Andrew was mentioning, could maybe not just be used in people with new onset diabetes or to prevent diabetes, but maybe even people with established diabetes of even 50 years duration. So that research still needs to be done, but it offers really nice hope. So we're initiating a similar project in Canada, and in fact, we're collaborating with the Jocelyn Diabetes Center. And right now, we're in the phase where we are reaching out across Canada to try and just identify who the hell is out there with type 1 diabetes of 50 years or more, and learn some basic things about them through a questionnaire survey study. So we'd love for you to spread the word, diabeteslongevity.ca. If you log on to that website, you can sign up, you can get information. There's 1-800 number. We're asking for help from diabetes organizations in Canada to spread the word as well. And if you do hit on that sign up button, the person that will first see that email is Elise Halpern. Elise, do you mind standing up for a moment? So Elise works in my group. She has a neurosciences background. She's been breathed a huge breath of fresh air into this project and has been working tirelessly to get this off the ground this past month. So I just wanted you to know this is the face that's behind all the secured emails. So what we're going to do in this first year is collect basic information. Do people with this duration of diabetes, get care from endocrinologists or family doctors? Are they likely to be on pumps or not on pumps? And what we're doing is collecting some similar data to what's been collected in the US, and we're going to make Canadian-American comparisons. That's phase one. Phase two is to now bring people who live within the area of the existing Canadian Clinical Trial Network into Toronto to do what we call deep phenotyping studies, where we're going to do those involved nerve studies as well as kidney tests and eye tests and heart tests, including a test called the coronary calcification, so that we can understand what these folks look like. And our hypothesis is based around the fact that there's a system called the renin-angiotensin system that's supposed to be the thing that really injures kidneys and leads to heart disease and strokes. We want to prove whether that's actually true or not, because most of the therapies that are being given to people with diabetes are meant to counteract that system. And if it's not true, like people can live with diabetes without having activation of this renin-angiotensin system, then we've got to really rethink our therapies, and it'll give us better direction for strategies for better preventing complications. And then our hope in the third phase is, as the Canadian Clinical Trial Network grows across the country, that now we'll have more sites to do these studies and have a beautiful registry across the country of those with 50 years of diabetes or more. I'll just say that as a team and as a diabetes community, we are extremely proud of people who've lived with diabetes for this long, and we recognize we have a lot to learn from them. And this is the time to make it happen, to grow it with the clinical trial network across Canada. Oh, so, sure, yeah. I thought you were going to tell me I'm out of time or something, so I'm going to look at my watch, because that would be fine too.
Are you people that don't have diabetes for 50 years, but whatever, are you keeping names of those people as well, and then when they hit the 50-year mark, you'll reach out to them?
Yeah, actually, we would love to do that. So we're encouraging people to contact us, let us know what stage they're at. We had to draw, so I told you I'd tell you about the extreme phenotypes approach, and then I didn't even describe it. So what extreme phenotypes means is take people who you can identify, let's say with long-standing diabetes duration, but who've not developed complications, compared to the group who might have shorter duration diabetes but have developed complications. If we make comparisons, they can be genetic comparisons, or we call proteomic or metabolomic, these measurements that we can make. It allows us discovery research to understand better what factors might be causing these complications. And so we are looking for people with 50 years or more, but there could have been very good justification to make it 40 years or more. And in reality, what we would have loved to do is a registry of everyone with diabetes, understand the continuum. And that might be something depending on our funding and capacities that we would do in the future. So to answer your question, if you know of people who are approaching 50 years or even not, have them contact us through diabeteslongevity.ca, and we would love to hear about them. So this is the website. So on it, can learn more about the study, about our team, and also as part of this, we are accessing the Jocelyn Medal to Canadians as well, providing that award. And someone, if they want to receive the medal with our help, they don't need to take part in the study. And if someone doesn't want the medal, they can take part in our study and not get the medal. And what we're doing, just to tell you, we just initiated it this last month in May. So we're aiming for 350 questionnaires, and we're up to 28 or so at the moment. So we're just starting, and we would love your help to spread the word. All right, so let me kind of review what I've talked about. I first told you about my involvement in the Canadian Clinical Trial Network, which for me has really gotten me in the area of artificial pancreas and sort of upped the ante and got me prepared to now be one of the few Canadian sites that are looking into artificial pancreas research. In fact, pre-existing ones have been through the Canadian Clinical Trial Network. That I told you about our pilot study, to have a tool that patients could use, either ultimately programmed into their pumps or as an online tool that can help guide them with adjustments of basal insulin so they can have safer overnight blood sugars to help prevent hypoglycemia and also to improve blood sugar control overall. I then told you about our initiative in the artificial pump program, but that most of my research initiatives until now have been focused around preventing complications, and I've had a big focus in neuropathy, which is an understudied area. My interest is being able to predict now who's ultimately at risk of developing neuropathy, so we can use better clinical management in those people or involve them in clinical trials that will actually tell us about what therapies could prevent neuropathy. And I hope you'll remember this concept of corneal confocal microscopy, which is a simple test that can be done in minutes and could be harmonized with the annual eye examination that people with diabetes have anyway. And then I also told you about our initiative we just initiated this past month, the diabetes longevity study, which I really hope that you'll help spread the word. So thanks for your attention.